My name is Samantha Guld. I am with AIM at Melanoma. I want to thank everybody. Oh, there I am. So I want to thank everybody for joining us today. Some of you are still at work in what is now the new way of working for many of us. So thank you for taking time out of your day to join us. I also want to thank, of course, our presenters today who have, some of them have just come out of clinic to give us some updates on what is happening in this day and time. A lot has changed over the last 2 months, and a lot of people have expressed concerns and have a lot of questions about what this means about being treated with melanoma. So I certainly want to thank the presenters and Moffitt for doing this for us this evening for what has now been a probably very long day for all of them. I also want to kind of give everybody out there a little bit of information about how we want you to be a part of this event. Unfortunately, this is not our typical event where many of us get to meet in person and interact and get the support that we need during this time. So there's 2 features I want to point out at the bottom of your screen. The first one is a chat feature. It's a little bubble and it says chat. And so if you want to reach out to others in the audience and share your experience, ask questions, we want to encourage you to do that. If they don't respond, that might be because they are watching this event and just don't have an opportunity to share with you as well. But if you feel so inclined to participate in that way, we want to encourage you to do that. Also at the bottom there is another button with 2 little bubbles as Q&A, and that is your opportunity to, just like with any of our other events, to reach out to the presenters and ask questions. So please use those 2 features. A couple of other quick things. Immediately after this event, you're going to receive a survey, and we're going to ask you to please to respond to it and give us your feedback. We're going to be having more of these over the next few weeks and months, and we will be using that feedback as programming. And on that note, our next webinar, our symposium, is going to be with the Cleveland Clinic. We don't have an exact date. It either will be next Thursday, May 7th, or in a couple weeks from that. And they're going to be sharing with us some of the other things that are affecting our lives: diet, exercise, things that are more non-medical, but are certainly very important to having a quality of life. So without any further delays, I want to introduce Dr. Sondak. Thank you so much for being here, and the floor is all yours now, or I should say the screen.
Thank you very much. We're delighted to be able to do this. We know how much this current coronavirus pandemic has changed everyone's life around the entire world, and I don't think anybody's lives have been disrupted more, with the exception of the people who are actively in the hospital fighting the COVID infection, than our patients who are suffering with cancer. Cancer is still one of the leading causes of death and medical illness in the United States today, and it hasn't gone away because of the coronavirus, but all the things that we're used to doing to take care of cancer have been disrupted because of the virus. And we're here today to try to give you, as patients, as family members, as caregivers, and supporters, some information about what are the pros and cons of going ahead with treatment, what are the risks of getting treated in this environment, what are healthcare providers doing to take into account the virus and to protect you when you come to get treatment, what is safe to wait on and what is necessary to proceed with. We also want to give you some ideas of what are some of the resources that you can fall back on if necessary. And finally, we want to be able to answer questions. We want to be able to address some topics about things like, is it still safe to be in a clinical trial? And What would happen if I got sick while I was on the trial? All kinds of things you might not have even thought to ask. So we're going to try to do this in a sequential fashion, ask each of our expert panelists to provide a brief overview about what are the consequences of getting treated in this environment, which things are we putting off, what things are we changing. And to start that process, one of our melanoma expert medical oncologists, Zeynep Eroglu, is going to talk about drug therapy for melanoma in the COVID-19 environment. Specifically, if I need adjuvant therapy because my melanoma spread to the lymph nodes, what are we doing differently today than we were doing 6 months ago? If I have an enlarged lymph node, a big mass, what are we doing today differently than we were doing? And if I already have metastatic disease and I need treatment or I'm on treatment, what are we doing differently? And Zeynep, before you start, I want to let everyone know that just this evening, 4:30, we just got the word that pembrolizumab was approved by the FDA at the 6-week dose. So you might want to just cover whether that's something that will be relevant to people or not. So without further ado, Zeynep, just a brief overview of what you're telling your patients today and what advice you are giving to patients about when to wait and when to go forward.
Right. So with regards to specifically focusing on the adjuvant melanoma setting, so generally these are our patients, with stage 3 melanoma who've had, surgical resection and then generally come to see us, medical oncologists, following their surgery for discussion of, preventative treatments, such as with immunotherapy drugs or with BRAF-targeted therapy drugs. So I think just to keep in mind, there is a little bit of flexibility upfront on how quickly these treatments need to be started in the post-surgery, preventative setting. If we go back to the trials in which, immunotherapy drugs, targeted therapy drugs were administered, the drugs could be started, as late as 12 weeks after the time of, surgical resection of the melanoma. So perhaps, for some of our patients, who recently had surgery and, would like to, avoid, starting treatment right away, where they would have to go into their oncologist's office or to their, cancer center, potentially, having a little bit of a delay there, even as much as 12 weeks from the time of surgery to start of their adjuvant drug treatment, would be very reasonable. So again, a patient in that situation, who's been rendered, as far as we know, disease-free post-surgery, does not, need to immediately start on preventative treatment. In terms of the types of drug treatments, and again, this is, it's a very long discussion that we have, on which group of patients to offer these treatments to, but typically for our patients, at least with, stage 3B, 3D melanomas, and stage 4, of course, we do have the options of the immunotherapy drugs and the targeted therapy drugs. So briefly, with the immunotherapy drugs like the nivolumab, Opdivo, or pembrolizumab, Keytruda, essentially these are the only drug treatment options for our patients who have BRAF V600 wild-type melanomas. We do have some differences in regimens to choose from. So I think, especially in the current times, to try to minimize as much as possible the number of visits that our patients would have to make to the cancer center, to our infusion center, we may preferentially treat with nivolumab, which we can give, every 4 weeks. So essentially, a patient will have to come in once every 4 weeks, for their infusion, as opposed to the every 2-week regimen. So every 4 weeks, and you would cut down on the number of visits required. With regards to what Dr. Sondak just mentioned with pembrolizumab, so traditionally, we've been given pembrolizumab every 3 weeks, as that was previously the only FDA-approved regimen. But given, the news today of the every 6-week regimen also becoming approved, so that may also become a treatment option in the adjuvant setting to cut down even further the number of visits that our patients, would have to make to the infusion center. So perhaps only having to come in once every 6 weeks for treatment, on pembrolizumab as opposed to every 2, 3, or 4 weeks. And then we do know that for our patients who have BRAF V600 mutant melanoma, those patients also have an alternative to immunotherapy, which are the BRAF MEK inhibitor, the targeted therapies, which are pills. So potentially for those patients, they may be able to even cut down further on the number of visits that they have to make to their oncologist's office. Again, there's a lot to discuss about, immunotherapy versus targeted therapy, but essentially with the targeted therapies, as they're pills, you would take them at home, and in terms of following up on side effects, toxicity, how a patient's tolerating them, traditionally we do those visits in clinic, but I know we've been utilizing telemedicine more and more, so it may be possible for a patient on, adjuvant BRAF MEK inhibitor targeted therapy, they may be able to do, follow-up visit, via telemedicine, with their oncologist just to review their side effects and how they're doing, and then perhaps, again, cut down on the number of visits that they have to make.
Okay, great. We do have a question or two that I wanted to ask you, Zeynep. As you know, when you give immunotherapy, it's boosting our immune system. That's probably a good thing. Do we know whether that makes you better off if you were to get the virus? Does it help? Does it hurt? And then on the flip side, we also know that if you get immune therapy and it works too well, we have to put people on steroids to tone down that immune response. Are they at higher risk because they're on steroids? And then that would fall into two categories. Let's say they just have to be on replacement steroids long-term because of endocrine dysfunction, versus they have to be on high-dose steroids because of side effects, and every time they try to taper it down, the side effects come back. How would you advise a patient in any of those scenarios?
Right. So I would say at this point, we have some anecdotal data that's been, some of it's been published or, presented in, virtual conferences by different groups across the world, some data from China, some from Italy, Spain, and France. With regards to, specifically patients, of any type of, cancer who are on immunotherapy, it doesn't look like, again, keeping in mind this is, anecdotal and still not a lot of, not a lot of follow-up. It doesn't seem so far, at least, that patients, who are on immunotherapy, the anti-PD-1 drugs, CTLA-4, are necessarily at a higher, risk of either infection, COVID-19 infection, or, having a worse outcome, with COVID if they are, if they do become, infected during the course of treatment. I know there's some discussions, in virtual meetings in a group of patients in Italy. I think it was a couple hundred patients in hospital in Naples, and I think, out of only 2 of them had actually gotten, COVID-19 infection. I think there is some concern, well, to the other question, is it protective in any way? I don't know if we can necessarily say that at this point. I think, hypothetically, I think there's maybe there's some preclinical data published about, could it in some way make you less likely to get, virus infections? But I think, it'd be too premature to say anything about any protective effects. But I do think in terms of being more likely to get COVID-19, that doesn't seem to be the case. But there is some concern, I think, in patients who do, who do have COVID-19. If they do develop, acute respiratory distress syndrome, as a consequence of COVID, which is essentially a very pro-inflammatory state, could, having been on immunotherapy, could they potentially have, worse outcomes, as a result of that. And again, I think that there's been some experience, I think there were 2 patients, from a publication from China that mentioned some outcomes, but, worse outcomes with immunotherapy. But again, it's a very small number of patients. So I think at this point, I don't think we would say that being on immunotherapy is necessarily going to increase the risk of getting COVID or having worse outcomes. The high doses of corticosteroids, of course, is of concern, and I think, unfortunately, we do have to utilize high doses of corticosteroids, still to try to manage some of the side effects of the immunotherapy drugs. I think, we would just have to follow those patients very carefully. And one of the side effects to especially be wary of course, there's pneumonitis, this inflammation in the lungs. And, if we do have a patient on immunotherapy, we suspect is exhibiting signs of pneumonitis, of course, we want to make sure that they don't actually have COVID-19 and potentially consider testing them, if we're thinking of initiating high doses of corticosteroids.
Okay, thank you. Let's see, just seeing one more quick question, and that is, how long after treatments would you be concerned? Let's take the patient who got a year of adjuvant therapy and they got treatment or they went into remission after several treatments and they've stopped. Is this something we would still want to keep monitoring them very closely for?
I think specifically for patients who've been on, immunotherapy and are now, off treatment, on surveillance, we do know that when it comes to side effects of immunotherapy drugs, sometimes they can manifest even when the patient's off treatment. So we have seen patients, even rare, but even 3-6 months after their last dose, to have a side effect such as pneumonitis, that may require corticosteroids. So, and we always do tell our patients, even when they come in for their very last infusion, on adjuvant treatment, for example, that, to let us know if they do, exhibit any symptoms, even afterwards, because it could still be from the immunotherapy. So I would say, to still be aware for about, the first 3-6 months post.
So they may still have some positive effects and they may still be at risk of having some adverse side effects. Let's talk about a slightly different form of treatment. Let's talk about radiation therapy. We're very fortunate at Moffitt to have Evan Wuthrick, who's a radiation oncologist who specializes in all types of cutaneous malignancies, including melanoma and other skin cancers like Merkel cell cancer and squamous cell cancer. Radiation isn't the main treatment for most types of melanoma, but it's very important for some types of melanoma. Melanoma metastatic to the brain, desmoplastic melanomas, and some forms of node-positive melanoma. Evan, how has the current situation changed what you've recommended to patients about treatment with radiation? And how have you had to deal with radiation in a patient who might have an active virus infection?
Yeah, thanks, Dr. Sondak. The first thing is that many, many years ago, when cancers were first being tested in laboratories, it became apparent that melanomas, on average, are not as sensitive to radiation therapy as some other types of cancer are. And so it takes generally, on average, a little bit higher dose given per session for melanoma. And so we have favored for a long time using a small number of doses of radiation finally focused on a particular area as the best pathway in melanoma. And so things haven't changed that much with that recommendation, because we were sort of already trying to do a few number of doses, larger doses per day in a finely focused way in melanoma, but even more so in the era of trying to minimize trips to the hospital, to the healthcare environment. We've advised our patients and tried to design plans that give a higher dose per day focused on a particular area and very finely focused, so that we're trying to minimize dose to those target tissues or to the non-target tissues. We have advised patients, similar to what Dr. Eroglu was talking about, that if they need to have radiation therapy, for example, after a surgical operation to try to reduce their risk of a recurrence, that radiation therapy can occur in a window between 4 and 12 weeks after surgery. So it doesn't necessarily need to occur right after surgery. And we have no evidence that treatment, directly after surgery is any better than within 12 weeks. So there's some opportunity in there to schedule things in a time that, may be better as far as the overall risk to patients in coming out to the healthcare environment. And then I think we have had the experience at Moffitt of treating patients who have COVID-19 infections, not in this case specifically for melanoma, but for other conditions. And that has been done and successfully done and treated patients to the lung that had COVID-19 infections. We're very conscious of making sure that we keep that patient and our staff safe with the use of personal protective equipment during that time, but this can be done. Radiation therapy seems to be tolerated safely. And in general, all of the organizations that help to form expert opinions about radiation therapy have advised to minimize the amount of radiation therapy done to COVID positive patients, to be thoughtful about the radiation therapy regimens that we're using, and whenever possible to use hypofractionated, so a small number of fraction, higher dose per time regimens in diseases, in all sorts of diseases. And so those are the kinds of things that we're doing and the kinds of ways that we've sort of changed or adjusted our thinking in response to the viral pandemic.
Terrific, great information. I would want to add one particular little warning as a surgeon. I'm a surgeon, a surgical oncologist. When we're doing all these treatments that we're talking about now, immune therapy, chemotherapy, radiation, surgery, it may well be appropriate. At Moffitt, we have the technology to test people in the day or 2 or 3 before their surgery, before they start on treatment. That's helpful to identify the patients who have an active infection and then allow us to make a decision. Gee, can this wait? If you're actively fighting COVID right now, maybe you're feeling fine today, but in 2 days, you're going to have a lot of trouble breathing. Maybe that's not the ideal time to have a surgery with general anesthesia. Maybe we can put this off for 2 weeks and get you through the worst of it. So testing strategies are an important part of safe conduct of treatment, including surgery. One of the things that we're starting to see is that COVID infection, potentially even in patients who were not symptomatic at the time they had surgery, may have predisposed people to more blood clots. So be cautious of that. And if you were to get swelling, pain in the leg, something like that, that could be a sign of a blood clot. Get that checked out right away. There are so many things we're still learning every single day about COVID-19 and all the different symptoms. The CDC just changed some of the presenting symptoms that they're listing on their website as we got more knowledge just in the last few days. So a lot is being learned, and clinical research is so important in that. We're very fortunate today to have Allison Richards. She heads up our entire group of clinical trial coordinators, helping us do clinical research in melanoma. Allison, is it still safe? Is it still even possible to get on a research trial in melanoma today? And what happens if I'm on a trial and I suddenly get a COVID infection? What do we do?
Absolutely, thank you. So yes, clinical trials do not stop. Even during COVID, it's still very actually rampant, in which we're enrolling patients on clinical trials. I think the one piece to remember, to piggyback off of what you were saying, Dr. Sondak, is that we're learning so much about COVID in the clinical trial setting every single day. So things are changing, processes are changing, just for us to be able to keep up with the demand that comes with the clinical trials. And basically what we follow as a whole as an NCI designated cancer center is we do align with what the federal regulations and the NCI regulations stand, and just kind of work off of what our capabilities are here at the institution. So with that being stated, and with knowing that clinical trials are continuing, the main thing that we focus on still, whether COVID was a part of this or not, is your symptoms, and we pay close attention to that. And at the recommendation of our physicians, if it's deemed necessary for testing, we do proceed with testing of COVID. And if there is a case in which a patient was found positive that is on COVID, it does not necessarily mean that you're no longer able to participate in the clinical trial or that treatment stops. I think what happens is that every patient is assessed individually and then a plan is made thereafter. So it's very likely that yes, treatment will be held for a specific period of time until it's deemed safe for you to continue treatment in the future, or it could potentially be a recommendation of your physician for you to stop treatment altogether. But it does not mean, again, that everything is no longer in play. So we just kind of take it one day at a time, I would say. And with regards to the possibility of a positive patient, we're even moving towards actually having clinical trials that are specific for COVID. So that's just a little quick take on what we're doing in clinical research.
Terrific, thank you. I'm going to ask next Darcelle Welker. She's our clinic manager. She's a nurse who's worked in melanoma for many, many years and now runs our entire cutaneous clinic. So she's my boss. And what are we doing to keep our patients safe? What should patients expect when they go to the clinic or to the hospital? And what should they be doing to keep themselves and their loved ones safe as well during this time?
Well, thank you for having me on. This is great to be able to be a part of it. First and foremost, we want to keep our patients safe at all times and have them continue to get the excellent care that we are known for at Moffitt. So that first and foremost hasn't changed. Like everyone has been in this whirlwind of COVID, so many things were changing so rapidly in the beginning. It felt like policies within the hospital were changing, by the hour. Do we wear a mask? Do we not wear a mask? Who wears the mask? So I won't put you through the rigors of how that all went and just kind of give you where we're at now. So we have decreased the entrance points into the buildings. So when patients come for their appointments, they are asked some screening questions and their temperature is taken. We ask them if you had a fever, sore throat, a cough, any congestion, body aches, chills. We do take their temperature. If they screen negative for everything, they are given a mask. And they are asked to wear their mask throughout their visit in the building. I know sometimes that's difficult and it's uncomfortable and it gets stuffy and warm, but we are asking that the patients do try to keep that mask on it as much as they can. And then same with staff. Staff is all wearing a mask in any face-to-face interaction with the patient. There might be more PPE worn if, you know, we're doing a swab or doing something that's might cause coughing or sneezing or that kind of thing in close proximity. So all staff, you know, is wearing a mask at all times, surgical mask, and the patients get a surgical mask, like I said, when they come in. So we have also limited visitors. We started limiting visitors. First, it was only bringing one visitor, and now we are actually requesting that there not be any visitor with the patient unless it's deemed that they need a visitor due to a physical or mental incapacity of some sort. So we really are trying to protect each other and the staff and other patients. We're practicing social distancing. We have really big lobbies, which we're super fortunate to have in the clinic that we're in. So we are able to seat patients as they're waiting farther apart. So that's been great. And then more and more of our visits are changing to telemedicine. So if we can keep the patient at home and get a good visit and be able to do what we need to do that way, that's a great way to still get that one-on-one care with your doctor and be at home and be safe. So that's our mission, is to keep everyone safe. Family members can join in on their patient's visit, either using their smartphone. We can set them up with a Zoom. So if somebody's waiting in a parking lot or in their car or outside the building, they can get on their phone and be real time with the patient.
All right. Thank you, Darcelle. Now, being separated from their family members at the time they're coming in for their appointment, their treatment, they're hearing about their diagnosis, they're trying to decide to go on a clinical trial. That's just one of the many huge stresses that that COVID-19 is adding, piling on top of the stress of dealing with a disease like melanoma. I hope that most of these speakers and the information they've conveyed has provided some positive feedback, some optimism that it's not all bad news, that there is a light at the end of the tunnel, that we can still take care of people successfully. But we have to acknowledge that this is an awfully tough time and nothing has happened that has made it easier. It's all made it tougher. So we've asked one of our social workers, Christina Macnamara, who specializes in patients with melanoma and other cutaneous malignancies, to reflect on that, to tell us about how we can help you deal with some of those stressful aspects that are made even more problematic in the current situation. Christina?
Hello, I'm Christina. Like you said, this is Moffitt behind me, by the way, the aerial view. So this undergoing a stressful experience of cancer treatment is significant in and of itself, and then strap on top of that COVID-19 restrictions and concerns and other complicated medical worries really escalates people's anxieties. And if there's been any inclination toward anxiety, honestly, this exacerbates that. So there's no magic pill recommendation, but what I've been seeing of people, they've expressed most concerns of not having their loved ones with them. It stresses them out. They don't have that other set of eyes and ears in the room with them, with their physicians, to hear everything that's happening and to understand. They don't have a hand to hold during infusion. It's very overwhelming emotionally for a lot of people, and it is a bit of work to rethink how to deal with your medical appointments. So I encourage folks to communicate with their physicians with the nurses on what would make them most comfortable. It's having that loved one on the phone with them, doing a conference call, Zoom, whatever is most convenient. I know every practitioner at Moffitt is willing to accommodate people in that manner, and I'm confident that in your local centers that they would do that as well. I know that if a lot of folks have told me what they usually do to reduce anxiety, they don't have access to. They can't go to the gym, they can't go for walks, they can't do any of the regular things that help them cope with stressful situations. So now may be a time to think about engaging in different things that might help calm your nerves, reduce your anxiety. I actually put together a real life puzzle the other day with my stay-at-home roles lately. Haven't done one in probably 10 years, but it was a good thing to kind of just slow down the pace and not be looking at the computer or worrying about other things. That's just an example of ways to reprogram yourselves during this experience. And I'm also wanted to speak to some resources that are available out there. That there are a number of government programs that have come to play with COVID. There have been some specific changes to federal rules, for example, extensions to FMLA and so forth. And so I wanted to tell you all about some resources available online for you. I have a list that I sent to Sam at AMET Melanoma. So part of, at the end of all this, if you want to see the list of resources, you can get that through AMET Melanoma after the seminar. So, but just to point out a couple in particular, there's triagecancer.org. If you're still working, triagecancer.org is a wonderful resource. They keep up-to-date legal information for employed people with what their rights are, with their employers, with the federal government, protections they have through ADA, and they have a whole blog now on COVID changes and federal programs. There's also other organizations like cancercare.org. They have extra monies for folks who are struggling with not just cancer, but with COVID. That's an excellent resource to go to. There's a whole bunch of them. Keep in mind with each of these financial resources, they're often grants that they have. So sometimes you'll go to the website and then you'll find that the grant is closed. Don't let that discourage you, because there are other avenues out there that have financial resources for you. Most of them are accessed doing their applications by phone. Give them a call. They're not doing a lot of by mail anymore. You have to get online if possible, but starting with a phone call is an easy way to see if you are eligible for the resources that they offer. So that's it in sum that I have to offer to this conversation.
Terrific. What about sort of a catastrophic sort of scenario that I've heard a couple of people bring up? All this economic upheaval. If I lost my job, could I lose my health insurance? Are there some things that people are trying to do to deal with some of the economic consequences of this pandemic?
Well, the triagecancercenter.org, I apologize, triagecancer.org, they have more up-to-date information on things like that. So they talk about resources such as COBRA, if you were employed with insurance and then you lost your job. I do know that they have made some extra allowances for COBRA and extensions and so forth, because since the COVID-19 pandemic has caused so many more employment issues than before. So I would say go to triagecancer.org, because I don't know all the ins and outs, but I do know that there is more flexibility now with the resources that are available. I know what you've all read, that what I've read too is that unemployment checks unemployment's not being processed in a timely manner. The checks aren't really coming quickly and aren't covering everything. And it's going to feel like piecemealing these resources together because, for example, cancercare.org, if you're eligible, you can get $250. For, Family Reach, you can get $350. It's a bit of a process to gather some income during this, but there's no one big way to give you a lot of financial security right now. And I'm not saying that to be discouraging, but I'm explaining it as a reality of the way it is, and to encourage you to look at multiple avenues for assistance during this time.
Great, and let's change the focus ever so slightly, and because there are a lot of family members and caregivers and supporters that are probably going to be watching this webinar. What advice would you give to them for how they can help their loved ones, their family members who have melanoma? They may not have COVID, but they're hearing all this stuff. Is it helpful to clip out every article in the newspaper about, COVID and cancer? Or what is your advice? Any suggestions for how supporters can pull together and help somebody going through their cancer diagnosis in this condition?
Gosh, that's a tough question nowadays because that is one of the concerns that patients have said to me, is that they don't have available caregivers. Their daughter can't fly in from Michigan to help them after surgery. Their brother is in Georgia and can't come down and drive them back and forth for treatment. It's a very difficult time for all families. If you are a caregiver and present and available, being able to do things for your loved ones, if able to get them groceries and bring them to the home, to bring food, things like that, since we're all being protective in our homes. I personally discourage getting internet overload, information overload. There's so much information out there. It's overwhelming. People can get fixated on that. I would encourage caregivers to be a calming presence in their loved one's life, engaging in positive activities, in encouraging activities, and providing the assistance that way. And something to think about also as far as support for one another. And I know that AIM at Melanoma has a peer support program for patients as well as caregivers. There's also another program called Immerman Angels. And these are peer programs where they assign you with a mentor so you can talk to them by phone. And so no one has to leave their house or go places. But that can be a good resource of support for the caregivers and for patients individually to help them cope through such challenging times, because caregivers need their own props along the way.
Great suggestions. It's certainly, I've heard the same thing from patients a little bit about, thank you, I know you mean well by sending me every single link to every story that's on the internet, but it's a little bit overwhelming for me right now, and I want to focus on just a few things. So recognize that what you may need might be different than what your family member with melanoma might need. I do want to remind everyone that if you are listening live and you have a question, you can use the Q&A feature to get your question asked. We still have one or two that I'm going to try to cover, but before, I just wanted to remind everybody on that, and then I want to just temporarily send us back to Samantha Guld to follow up on a lot of what Christina talked about, with some specifics about what AIM at Melanoma is doing to support patients and families and caregivers. Sam?
Thank you, Dr. Sondak. So a couple of things. First, I just wanted to go back to, if you don't mind, a comment that Christina made about how caregivers can support their loved ones. So one of the things that we are hearing from people is that when they go to their visits or they're in the hospital, they're not able to have their loved one there with them. And even just somebody's presence can be a huge support for those people who are going through this difficult time. And what we're hearing from patients is, and some of the physicians are allowing it, is to use our phones and to actually use FaceTime, so that when they are having these discussions with their healthcare team, they have an extra set of ears. So that person may not physically be in the room, but they're hearing the discussion and being able to participate in it. And so that when they go back, the patient isn't being required to repeat everything over again. And it's a way of making sure that they caught everything that's being discussed. Answering the question what AIM is doing. So Christina mentioned our Peer Connect program. So it is a program we've had now for some time, and we are matching newly diagnosed patients with those who are further out into their journey, as well as matching caregivers and family members with others. And they're supporting each other, especially during this difficult time. You know, we're all in a new place. Nobody's ever experienced this before. And so if you need that support, you have somebody hopefully there who can help you through it. We also have a physician assistant who works in a clinic outside of AIM. And so she's got a lot of practical melanoma experience. And so it's a free toll-free number, or you can email her in a form on her website. And she's happy to help answer those questions. And then when you need the specific information, then encourage you to go back to your medical provider to get specific questions answered regarding your care. And we're running a lot of these events. So we have not stopped. We are pivoting. So some of the topics that we normally would have been discussing in a very typical format, in either in a conference room or at a meeting, we're going virtual, and we're making it available via on webinars, on our Facebook Live. And so there's a lot of information that we are sharing, and we're making sure that it's very relevant. So those are the three big things that we are doing to keep everybody informed and to help support you. Thank you.
Great, thank you. I want to cover a couple of topics, both from the questions that we've been asked, and call on all of our panel to help out when necessary. First one is, we've talked a lot about what caregivers and health providers can do for the patients. What can the patients do for the providers? And I want to start by saying the first thing is, one of the goals that we had in this webinar is to reassure people that it's not either or. Either I have to get my cancer care taken care of and risk my life of getting COVID, or I have to worry about COVID and ignore my melanoma. We are learning together how to take care of both, how to integrate the care. So please talk to your healthcare team, be honest with them, and understand that it's not going to put you in some negative position if you tell people, I have a fever, I've started to cough. They're not going to just put you aside and say, we're not going to take care of you. They're going to try to be appropriately mindful of the higher risk that might happen if you get treatment, and the higher risk that might happen if you delay treatment, and find a balance. So please share all of your information with your care team that you possibly can, and help us help you. It's so important that we have all the information that we need to take care of you. One example is side effects. We need to know what side effects you're having, if you're getting ipilimumab, if you're getting pembrolizumab, if you're getting ipi-nivo or BRAF targeted therapy. You may not know whether that's a side effect of the drug or of having a COVID infection. We may not know, but we will probably say, gee, that sounds unusual. That sounds concerning. Let's look into it. We want to know, and we want to hear about that. Other comments from the panelists about what patients can do to help their healthcare team, help them through this process, if anybody wants to jump in on that one. Just don't forget to unmute yourself.
I think I would just, what Dr. Sondak said in terms of, you know, just letting us know that any symptoms that you may be having, you know, if you are, you know, someone who is on active treatment, you know, I think one of the questions has come up is immunotherapy, you know, and having the side effect of pneumonitis, this inflammation in the lungs, and certainly, you know, we do everything possible to try to differentiate, you know, this is a side effect and to treat with, you know, corticosteroids versus do we need to do further testing, you know, similar to targeted therapies. Do you have targeted therapies which can have a side effect of, you know, and sometimes, you know, we may need to try to differentiate, is it just a fever from the drug and uphold it and watch versus do we need to do further workup? I would also say, I would also recommend communicating, you know, with your oncologist office about, you know, if you have any concerns about coming in or wanting to, you know, delay or hold off on routine scans that you may have. You know, we were discussing earlier about patients getting treatment in the adjuvant setting, you know, where they would presumably render disease-free by surgery, where we do have some more flexibility potentially to hold off on some treatments. But to keep in mind, for our patients in the metastatic setting, you know, we do have, you know, active cancer that we're trying to control with these treatments. You know, I think it'd be important for your oncologist office to be aware, you know, if you have some concerns about coming in or you're wanting to delay treatment, to really have the discussion about, you know, the risks of, you know, what that may entail, risks of delaying treatment or holding off on scans, you know, just to avoid any unfortunate circumstances where, let's say you delay scans, fortunately there's progression of your cancer and we don't know about it. So I think that communication with the office and specifically with the oncologist would be important, especially for patients who are on active treatment in the metastatic setting.
Okay, and we have a question about someone who received treatment in the past, got treatment, whether it was adjuvant or otherwise, maybe had some side effects, has gotten over them, is not on steroids. It's a year or two later. Just the fact that they have a melanoma diagnosis, or just the fact that they got treatment in the past, is that what people are talking about when they say comorbidities give you a higher risk of having problems or getting COVID, or do we think that those patients who got treatment a year or so ago and are clinically fine are at no worse of a risk than they would have been if they hadn't gotten this cancer diagnosis? Do we have any way to even assess that?
I think with the data we have so far, you know, from the experience of different countries that's been reported to date, I think what we're thinking of and what we've seen in terms of higher risk group of patients with cancer are those more with, you know, currently active disease, metastatic disease, and really the ones, you know, we haven't talked much about who are on active chemotherapy drugs. And who may have a worse performance status, you know, what we call this ECOG, you know, 2 or higher, patients who tend to be more frail. So I think we have some preliminary data that, you know, if you are unfortunately more frail as you're undergoing your treatment, you know, you're more advanced cancer and you're on a chemotherapy drug, I think it has been shown that those patients can certainly have, you know, increased comorbidities, and if they get a COVID infection, unfortunately, are at a higher risk of having worse outcomes. But, you know, someone, you know, who's been, you know, treated for their melanoma, you know, several years ago, who's just on, you know, surveillance scans, you know, that's not someone I would think of as being high risk just because they had melanoma treated a few years ago.
All right, and here's another question that we had come in. I'll put it Evan on the spot, even though it's not directly related to radiation, but the question is, we talked a little bit about screening and COVID testing for an active infection. What about antibody testing? Is that something that you're ever doing before treatment or in the follow-up of patients? Are we advanced enough in our knowledge about antibody testing to be able to use that in helping to decide who should get treatment or who doesn't, who we don't need to worry about?
Yeah, it's a great question. Thank you for whoever contributed it. I don't think that we're currently at the point of this pandemic that that's a useful strategy yet. I think that we can envision a day at some point in which individuals will know whether they have antibodies to the virus and will much better know whether those antibodies actually confer immunity to a future infection. There's still some question about whether that's true and for how long that immunity lasts. So we're still very much learning about this virus and how it works. For right now, most medical centers and particularly at Moffitt, our radiation oncology center is screening selected asymptomatic patients, not with an antibody test though, but with the actual nasal swab test that tells, if the virus RNA is there. And the purpose of that is because some patients can be because some people that have the infection can be asymptomatic, and we want to identify those people as soon as we can so that they don't cause an infection in the other people who might be being treated, especially recognizing that some of those patients that may be treated, in the rooms after them may be significantly immunocompromised, may have had significant chemotherapy drugs that reduce their immune system, bone marrow transplants, or a whole panoply of other things that may increase their risk. So we're currently screening patients that are undergoing higher risk procedures, so surgical procedures, scopes where somebody looks in their nose or in their throat, or situations in which our staff will be interacting with their mouth or their face or their lungs, or a patient might be coughing, those kinds of things. So that's the first step. And then, but as we develop better antibody tests, and as those antibody tests are more available and have quicker turnaround, and we know much more about their accuracy, we can all envision a potential future in which those are used a lot more.
We've got a couple of questions about patients with melanoma having trouble getting in to see their dermatologist. Either they think maybe they've got another skin cancer developing, or they're just being told my dermatologist's office is closing or putting off routine visits. We are certainly seeing that across the country, including here in Tampa. Many dermatologists around the country are trying to do virtual visits, but it is very hard to carefully examine and even diagnose all forms of skin cancer, including melanoma. On the video screen, you can see my picture. It's not such a good one that you could tell if I've got a melanoma somewhere. And so it's a big problem. I would say you've got to pay at least as much, if not more, attention to your skin now. And if you notice something changing, by all means, bring it to the attention of your dermatologist. If you can't get through to the dermatologist, to your oncologist or surgeon who's helped take care of you. If you can't get an answer, aim at melanoma. One of the things they've always done extraordinarily well over the years is leverage their connections to put you in touch with someone in your vicinity who can help. At Moffitt, we are helping the community dermatologists and seeing some patients and doing some biopsies for patients who can't get into the dermatologist, where in the past we would never have to handle that particular type of patient because we just say, go to your dermatologist, they'll get it checked out. All of us have to help each other, help out, and recognize the unique circumstances that we're in. But again, patients can help out by being proactive. And if you can't get to your own dermatologist, go back to your care team tell them that, or again, as I said, rely on AIM at Melanoma. They may be able to help make some connections that you couldn't make on your own. We are getting close to the 1 hour mark. Sam, you want to make any other comments or ask any other questions to anyone on the panel?
No, I think you did a great job. Thank you. I want to thank everybody for tuning in today. Hopefully this information really comforted everybody in knowing that that you are being watched over by the Moffitt team here and from AIM and from all of your healthcare providers. If you are seeing somebody right now, we encourage you to reach out to them and find out specifically what they are doing so that you feel comfortable knowing how that your treatment is not being compromised. I'm sure they're doing something, and that communication is, always very important. Thank you so much, Dr. Sondak, all the other presenters. We really appreciate you taking the time after it's been a very long day, week, couple of months. This was literally to everybody. We reached out to them about a week ago and said, hey, will you do this for us? And everybody just, there wasn't really a question. Everybody said they'd be willing to pitch in. So thank you very much. Again, we will be holding more of these going forward in the future. If you have not registered for this event and you received the link from somebody else, please reach out to us. We will make sure that you learn about new ones that are coming, that are just around the corner. So thank you very much. And thank you, Dr. Sondak.
And thank you to AIM at Melanoma for all you've been doing and supporting both patients and healthcare providers. We truly are all in this together, but we also truly are all experiencing this very, very differently and all affected very differently. And the more we can understand that, the better off we all will be. So thank you all. And thank you to all the panelists for dedicating your time to this.
Thank you.